to the second in our series of webinars for 2023. I want to apologise in advance because you can probably hear I'm really nasally and full of cold. But I'm still going to start the introductions for this session, and I may pass over to Oliver, who you can see there, to introduce each of our speakers. It's fantastic to be able to welcome so many attendees. We've had over 100 people sign up for this webinar, which is fantastic. And we have an absolutely stellar lineup of panel members from health estates experts from the UK and from Australia. So to have that cross-jurisdictional approach is amazing, and I'm sure we're going to learn a lot. Just to start a little bit about myself and ECF. So I'm Louise Bradley, an Associate Director at ECF. Prior to joining, I ran my own boutique agency for 15 years. And during that time, I've worked mainly in the health sector and supported around 300 projects, community engagement projects, including a lot for estates development as well. In addition, ECF has supported many complex built environment projects over the last 5 years, including working with the Community Health Partnership as well. So just a few practicalities before we start. Today's session will be recorded and we'll post the video link on our website. In addition, we're going to write a summary of the findings from today and email that over to everybody who's registered. We are going to use the Q&A tool to post questions. So there will be 3 presentations, and following that, we'll open the floor to questions. There's an icon at the bottom of your screen, which is the Q&A tool. If you click on that, then you'll be able to type your questions into it, which will enable a panel discussion to answer those. We are very mindful of the number of attendees for today. So if we're not able to answer all questions through today's session, then we will write the answers in the follow-up summary as well. So onto our panels. Sam, if you'd like to move the slide on to our panelist slide. Yeah, one more. Brilliant, thank you. So I may as well do this, Ollie, actually, as I'm still able to speak. Okay, so our lineup of speakers and panelists today include Natalie Forrest, who is the Senior Responsible Owner for the New Hospital Programme here in the UK with the NHS. Natalie is responsible for delivering 40 new hospitals by 2030, no mean feat. And she's a seasoned NHS executive and a clinician. She's delivered lots of complex projects and empowered that through teamwork and a shared vision. She also opened the Nightingale Hospital in London and is responsible for the fastest build of a digital hospital from concept to opening in the NHS. We're also joined today by Nicola Theron, who's the Director of Estates for North Central London Integrated Care System. Nicola works collaboratively with the estate leads across the system, including providers, PCNs, councils, and other partners to share best practice and maximise the shared use of resources in North London, with a focus on estates delivery and efficiency in population health, and also net zero, which I think is increasingly, obviously, very important. We're also really thrilled to welcome Rebecca Walk from Australia, who is the Chief Executive for the New South Wales Health Infrastructure. So Rebecca joined Health Infrastructure in 2008 and has progressed through various senior roles to take up the reins of Chief Executive. She was previously Executive Director of the Rural and Regional Projects and spent many years working in countries' areas to deliver critical health infrastructure, including overseeing New South Wales Government record investment in regional health. And we're also joined today by Catherine Cox, who was appointed as Chief Executive of Sydney Children's Hospitals Network in August 2020. Catherine has many years' experience as an executive within New South Wales Health and with the responsibility for a range of health policy, planning, infrastructure and strategic reform programmes. So we've got an absolutely amazing panel here. I should also mention that in terms of ECF, we have our UK operation, but we've also now set up our Australian operation, and Ollie is currently across in Sydney running that side of the business. So without further ado, I think we will start with the first of our presentations from Natalie. Natalie, over to you.
Thank you very much, Louise, and good morning, everyone, or good afternoon or good evening, depending on where you're listening from. It's quite challenging addressing an audience on a laptop, but it does allow us at least to be international in the true sense of the word. So I'm looking forward to telling you about my programme this morning. So next slide, please. So a little bit of an overview, and Louise kindly set out the mandate for the programme, which is to build 40 hospitals by 2030. But in essence, this is the biggest hospital building programme in England for many, many, many years. And any of you who know NHS health estate will know that it's truly welcomed by the NHS and definitely needed. The objective of the programme isn't just to build 40 hospitals, however, it's to transform the way that we deliver that healthcare infrastructure for the future NHS, and to shift very much from traditional ways of building hospitals to a design and build solution. And there are many reasons why we want to do that. One of the biggest challenges for the NHS building hospitals is that it's generally a one-off opportunity. A hospital only builds a new hospital once in its lifetime, usually. And of course, when you do standalone schemes, you miss out all of those opportunities of capturing learning, of being able to standardise an approach, and the economies of scale. So by bringing all of the schemes together, there are so many opportunities for this programme beyond just building new hospitals. We launched the concept of Hospital 2.0 at the end of last year with the construction and health sector. And I'll tell you a little bit more about what it is, but in essence, it will support the programme to speed up the delivery of our schemes, to reduce cost and delay, which historically have been the nature of schemes in the NHS, unfortunately. So if everything goes to plan, we'll be going faster, better and cheaper. That's the plan. Next slide, please. So I was just talking about what is Hospital 2.0. In effect, it's three components of the whole journey of building a hospital. It's setting out standard design and delivery solutions. So that's standardized components, rooms, departments, layouts, but also standardizing the best value procurement and modern methods of construction, which it is very much a buzzword in the UK at the moment, but something that has been around for many, many years. And really it's just capitalising on those opportunities. But it also is recognising the complexity of the buildings and the operating models that we're dealing with, and looking to integrate those standards into standard operating models as well, which in essence will look to de-risk the development of the programmes, to support best practice in the new facilities, and to look to find the very best practice and solutions for all of the challenges that the NHS is facing, such as the clinical workforce, applying the digital solutions that exist that have yet to be really embraced across the NHS. And of course, to build in sustainability into this project. That is not for one moment to suggest that this programme is going to change the way the NHS looks and feels, but it is definitely a vehicle for some real opportunity to drive change. We are a tiny nugget of the work that's going on within the NHS, but a really bright, shining light and an opportunity, we believe. And then overall, it's to look at accelerating the whole approach, and that is to look to build standardised assumptions into the business case process, to speed up that approvals process through all of the assurance that has to happen in order to ensure that we're getting value for money for the public, but also to look at some of those approaches that each individual organisation will do separately. For example, their demand and capacity modelling, and what can we do to set some clear standards and assumptions across the NHS so that we're comparing apples with apples, for example, and everyone doesn't have to reinvent the wheel each time. So that, in essence, is what Hospital 2.0 will do. It's very much a piece of work that's being done in collaboration between the programme, the NHS as a whole, and the individual schemes that are part of the new hospital programme. Next slide, please. So one of the things that everyone asks is, how much quicker will it be? Well, we believe that we can reduce the time it takes from the traditional way of building hospitals in England by 30%. And you can see that the real difference here is the time it takes to design, get business case approvals, and get enabling works done before the actual construction time frame starts. So it's very much an upfront reduction in time for this programme. Next slide, please. So when we talk about reference designs, I thought it might be useful just to look at the process that we're thinking about. So this will be no surprise to anyone, but perhaps a little bit of reassurance that we are starting with a clinical brief and working with clinical teams to set out best practice. And this is actually quite challenging, because in an environment where, I mean, those of you will know that, you know, the NHS is so busy, and clinicians are so busy, getting time with them to imagine the best and to aspire for a future world-class facility is exciting, but also challenging. So in this space, we haven't just engaged with frontline staff, although clearly we do, but also the Royal Colleges and international experts. And then from those clinical briefs, we can set out standard room designs and departments, looking at things like what is the best staffing model for a ward, for example, rather than just repeating what an organisation already has. We've been looking at setting out single rooms for new hospitals, which currently the guidance in England is 50% of a new facility should be single rooms, and we're driving to 100% from the evidence and experience of COVID, frankly, and international colleagues. That then allows us to put together a kit of parts, which we believe will unlock programme-wide procurement opportunities and speed up the process of building all of these hospitals at the same time. We'll be looking to modularise solutions, 3D, 2D, prefabrication, and a significant amount of off-site manufacturing, and again to dramatically speed up the construction process. And this is simply because building 40 hospitals all at the same time without changing the way that we do it is impossible. We will have to have integrated logistics, thinking about capacity sequencing. We'll have to think really carefully about how we make scope changes, particularly in design, and have a really clear manufacturing setup in order to be able to meet the requirements. And ultimately, we'll move to a full standardized reference design that will be able to be configured based on what organizations require, and will provide best value procurement. Next slide, please. So for those of you who are familiar with the programme, you may know that when we set out at the end of 2020, we inherited 8 schemes that were already in construction, and we have been learning significant lessons from getting them to completion. We've now opened 2 of those 8 hospitals, and the others are all in construction phases, some almost ready to open and others just starting on their journey. What we have really found is that the earlier that we're engaged in those schemes to support and provide expert input, the better our relationship with the organisation is, and also how we can impart the lessons that the industry already knows. We don't just need to learn from what we're doing now. So we have one point of contact from the programme into each organisation in order to ensure that there is a flow both ways, that we are learning from them and we can impart learning from other schemes to them too. The lessons that we've been learning, we're able to adapt to subsequent schemes, and we'll be continuing that learning journey throughout the programme. And in order to make sure that we do that, and not just learn and impart those lessons, but actually embed them in evidence, because something that clearly happens across different industries, but is particularly pertinent to health, is being able to provide evidence-based decision-making. So a lot of, for example, we've done a lot of research on the use of single rooms, and particularly in England, there is very little written evidence of the benefits and risks of single room environments. So we have committed to working with Anglia Ruskin University as an academic partner to really make sure that the lessons that we learn, the findings, and the evidence that we collect through this programme is documented well and tested and published. I mentioned earlier that we're engaging with the Royal Colleges, but also all of the regulatory bodies, so the CQC, the NICE, there are so many regulatory bodies that we're talking to, that we have a whole team responsible for ensuring that there isn't a single individual organisation or agency that isn't able to input or give their opinions into the programme so that they've been considered. That is the beauty of a national programme. It is a real challenge to ensure that everyone has a voice. And of course, alongside that, we maximise the opportunity for patients to have a voice, because ultimately this is a healthcare environment for them. And also something that we feel really passionately about is making sure that the staff that are going to work in these facilities have a voice. The programmes that we're working with currently will probably impact around 200,000 healthcare workers of some form, whether they're doctors, porters, pharmacists, physios, nurses, healthcare administrators. There are a significant number of staff, and it's really important that we listen to them too, because frankly they work in these facilities every day. And we're going to be branching out to other countries to share what we're learning, but also to gather best practice, and today is an example of that. Thank you. Oh, I have one more slide, but I think I've spoken for enough time.
Thank you, Natalie. I can already see we've had four really interesting questions come through. I'm now going to pass you on to Nicola. If anybody would like to type an answer to those questions, though, any of our panelists, in the meantime, please feel free. And I'll pass you on to Nicola Theron.
Great, thank you, Louise, and thank you, Natalie. A really interesting overview. And I sort of come at this from sort of the other end of the spectrum, perhaps. So I'm Director of Estates for North Central London. Just to provide a little bit of context, we have 1.75 million people, 11 trusts, 200 practices, 5 boroughs, and we have some of the highest, most prosperous wards in the country, and we also have some of the poorest wards in the country. So we are a classic London ICS. And I'm just going to briefly, I've got 10 minutes just to overview some of the work that we're doing, particularly with a focus around challenges and opportunities. So next slide, if I may. So what this next slide does, that's slide 4. What my first slide just provides is a bit of a context for what we do. Have we got my first slide?
We only had one slide, Nicola.
Okay, I sent you through 3, but nevertheless, I will, if we could just take that down, I'll come on to that in a minute. So if I can just provide a little bit of a framing and a context for what we do. We have 3 delivery challenges I am focusing on. The first of which is around strategic planning, the second around prioritization, and the third really is about collaboration and accountability. So from a strategic planning perspective, this sits at the heart of what my team does, because this is very much about enabling estates, just as Natalie has talked about, enabling estates to deliver transformational change in the way the healthcare is delivered. We need to do that at both the system level as well as at the locality level. And that is about bringing together all of those many stakeholders that I talked about at the beginning. That needs to be done both at the NCL level, right down to the PCN level. So we have a clear focus around linking these two together. And just picking up, for example, what Natalie was talking about around the hospital programme, one of our trusts is Moorfields, which is one of the 8 that Natalie talked about. So it's how do you take a global player like Moorfields, but at the same time be really clear the impact of that on one of our small PCNs. So strategic planning sits at the heart of what we do. Secondly, it's about prioritisation. In the environment within which we're working, we have to ensure that we go through a consistent approach to prioritising what we do and how we do it. And we have a process, we have a number of criteria that we're bringing to that. One of them is population health. Louise mentioned at the beginning, population health, for most ICSs, sits part of that opportunity. So ensuring we've got a balance of those criteria we're using, consistently applied to prioritise a series of projects. The third is around collaboration. How in the world that we're now working, which is around managing some of those interdependencies that Natalie was talking about, how do we secure delivery of those prioritised projects? And we can only do that by prioritising accountability and collaboration. Sitting below all of that is a capital plan. So how do we use the capital that we've got efficiently? And in NCL, what we've been able to do is secure an agreed percentage of our capital envelope to be invested in primary and community. And we are doing that on a recurring basis. So our strategic planning enables us to plan as we've just heard. And then sitting alongside that is also our green plan. How do we ensure that net zero becomes an issue for all of us, and that each one of our projects is delivering to our objectives? So that sort of frames what we as a team are doing within the ICS, working amongst all of those partners. I would then have just picked up 3 very specific delivery opportunities with some photos, but we can circulate those afterwards. I wanted to pick up 3 areas specifically, one of which was our primary care programme, the second our community diagnostic programme, and the third is a record digitisation programme. And just picking up what Natalie was talking about, really what we're bringing to all of this is we're bringing a standardisation of approach, we're bringing the ability to scale up with value for money that offers, but importantly, we're also bringing consistency in terms of our engagement with local partners. So for primary care, we've got 15 projects that we're on site at the moment, each of one being delivered with partners, whether those be local authorities, our NHS property companies, and clearly our GPs and our trusts. We've got 2 community diagnostic centres, really important part of the health policy agenda at the moment. We have 2 CDCs, one in an existing community hospital and one in a shopping centre. What that's helped us to do is deliver 100,000 additional appointments for diagnostics to meet our waiting list agenda. I'm very much picking up Natalie's point about how do we apply the lessons. That is very much the heart of what we are doing. Sitting alongside that is a very brief overview of records digitisation. And what that has enabled us to do is we have still in many of our GP practices got patient records, paper patient records, using up expensive space. So what we have done we spent last year 2.4, we're putting another 2 million into it this year, is digitising those patient records, freeing that space up for clinical and clinical support space. The real important part of all of this is that that spend has enabled us to use our revenue more efficiently because it's come at nil additional revenue cost. And that's now allowed us to use those 20 spaces for 370,000 additional appointments going forward. So this programme sits at the heart of our GP portfolio. So that just gives you a little overview of the projects that we're doing, the standardisation that we're trying to bring to it, very much using Shell and Core as the model, as Natalie was talking about, using capital to do the fit out in order to create the sort of revenue headroom being one of our major constraints within the NHS at the moment. What I wanted to do very briefly was just take you on to the next slide, which I think you have got, Louise, and just to really make sure that we've got the voice of both the patient as well as our partners and staff being heard. So if you could share that slide, please. It should have a link. I don't think you've got the sound.
Yeah, you need to enable the volume, Sam.
Less staff and less facilities for diagnostics. Need more. On top of that, there's enormous benefits. The benefit is that these places get. Do you name me a people talking about parking? So first of all, you can get parking better. You can get equipment there where there are good public transport facilities, and so it's convenient for the patients. And you can locate it where there is great location, for example.
Is anybody else struggling to hear the video?
Yeah.
Sam, I think you need to stop it and restart.
Yeah, I think so. I will just move on. So what that was really just capturing was the Wood Green Shopping Centre, CDC, and that point around how do we get care closer to those communities that have been hardest hit by COVID, which is very much the Haringey community. But it really importantly, how do we ensure that the voice of the patient, and there were a couple of interviews, very brief interviews with patients there around access, and a couple of clinicians, one that's on the screen as we speak, either coming back into the NHS because these opportunities are more convenient, they're more relaxed, and it creates a workforce opportunity for us to illustrate how the sort of investment that Natalie has been talking about can open doors in a way that's very useful. So just very briefly to conclude, I hope what I've shown you is that ICS estates have the ability to support both big change programs, the CDC as an example, but also prioritise ICP local care projects, some of the smaller GP practices I've talked about. It is a route to manage ICS backlog and the elective challenges in a way of really opening access to wider services. Really important that estates capital and revenue is the key requirement to enable this to happen. And we've been working hard to both use our own capital, but also the capital of landlords and planning opportunities. But without collaboration and partnership working, none of this is going to happen. And so sitting behind all of that really is the importance of trust, building trust, and those strong, effective relationships that Natalie talked about at the beginning in terms of giving us a focus around delivery. Thank you. Back to you, Louise.
Thank you, Nicola. And I'm sorry video didn't work there. Somebody has written within the Q&A, will we share the video link? And yes, we will. We'll share the presentations and the video link as part of our summary and follow on from today's session. So can I now pass you on to Rebecca, please?
Sure. Thanks, Louise, and thanks, Natalie and Nicola, for going before me. I'd just like to very briefly do an acknowledgement of country, which is something that we do in Australia to acknowledge the traditional owners of the land, the Aboriginal people and the Indigenous people. I'd like to pay my respects to elders past and present. I am today sitting on the land of the Gumbaynggirr people on New South Wales North Coast. And in the spirit of reconciliation, Health Infrastructure acknowledges all the traditional owners of country throughout Australia and our connections to land, sea and community. Part of what we do now with all of our new hospital developments is we try and do a lot more stakeholder engagement with Indigenous groups, and listen to what is important to them in the provision of services in our facilities, and that enables a lot more collaboration in that space and better health outcomes. If we can provide spaces where some of these vulnerable communities really want to come and attend to services, then we find that the length of stay is shorter, you get better engagement and much better health outcomes for families and communities in that space. If we can just go to the next slide, a quick introduction to health infrastructure. We have one of New South Wales Health's statewide services. Our vision is to deliver future-focused, innovative and sustainable infrastructure and support solutions that enable value-based healthcare. We view our clients as all of the local health districts. So my colleague, Catherine Cox, is joining us here today. She's the Chief Executive of the Sydney Children's Health Network, so looks after 2 hospitals, and we are doing major redevelopment projects at both of those hospitals. We are responsible for planning, designing, delivery, commissioning of any project over $10 million. We're in our 15th year. We are part of New South Wales Health, not a separate infrastructure agency. And our pipeline in the next 4 years is almost $12 billion. That provides us with a whole load of challenges, which Natalie spoke about some of those around supply chain and collaborating with our partners, particularly now as some of our neighbouring states in Queensland and Victoria also now have fairly major infrastructure programs. We work closely with our local health districts and collaborate with them around designing and co-design, much user group consultation, development of our functional briefs, to grow our health precincts into a really strong place where we're not just building hospitals as islands, but where we are building hospitals as places and precincts where people really can access and activate those places so that we have overall better outcomes. And I'll get to a case-specific example, which I'm sure Catherine can have some input into shortly. We lead a significant program of work on behalf of New South Wales Health. We are also now involved in an asset management framework, which is part of our treasury requirements now, around understanding whole of life cycle costings from the beginning to end of projects, so we can better predict when we need to have asset renewal in that space, and hopefully get one jump ahead of when politicians announce a new project, which isn't always the case, but it's around forecasting better facilities which are fit for purpose and sustainable, and optimises the asset value for everybody. We can go to the next slide, thanks. As I mentioned, we've got a nearly $12 billion pipeline. We have around 350 people in our team, plus consultants and contracting partners. Year on year, we have been growing since 2017. You can see a blip there in 21-22. That was primarily due to COVID, where we lost pretty much a quarter of our year and our cash flow due to lockdowns in New South Wales, and we're picking that up again now. And you can see through that we are steadily growing. We have about 130 capital works projects underway, which might be a program of rural ambulance stations where an ambulance station may cost $3 to $5 million, but because they're in a program of works, then they are delivered by our organisation, or it may be a major hospital in a metropolitan area or regional area hospitals. Our biggest projects are in the order of 1.3 billion Australian dollars, and we have any number of significantly sized projects which form part of real precincts, which I'd like to talk to you a bit about now. It is, until very recently, as I mentioned, it was the largest health infrastructure program in Australia, and it's certainly now still on par with our neighbours in Queensland and Victoria. Through our focus, we really need now to look at what resources we can have. We've got a much stronger mandate around sustainability. It's a key focus in delivering what we do. I was interested to see Natalie's response around sustainability and focus and the use, for example, of single rooms. Our experience is, yes, you may get better health outcomes from single and double rooms, and it is what we are doing here also. It does, however, drive your recurrent costings up because you need more nurses for better surveillance, you need more cleaners, you have different recurrent costs in that space, you have different design parameters. So we're trying to double all of that. So our economic sustainability and workforce sustainability with environmental sustainability as well. But it's certainly now moving, sustainability is now moving from an innovation in our space to something which is demanded as business as usual. And we are striving for carbon zero, carbon readiness, full electrification readiness, which one of our challenges here, I think we're behind the UK on the availability of green power. So we can get a facility ready for electrification and not use as much gas. However, the state may not yet be in a position to actually purchase green power for everything. If we just flick to the next slide, thanks. Health precincts are really a part of our strategic reform areas in New South Wales. Contemporary health precincts, which I mentioned, looking at a holistic approach to the co-location of clinical services with relation particularly to education and training is very important. Was interested to see Nicola's slides around putting some of those ambulatory care services and diagnostic services into shopping centres. We are finding we are doing that more and more here and looking at how we can have more holistic approaches, particularly around ambulatory care, but making hospitals and precincts far more activated, getting better transport options to and from, looking at what locations that any of those services are in, and to really support all of our clients in that space. We will deliver a number of programs and strategic initiatives for New South Wales Health to improve that health innovation, increasing partnerships. We have a role in commercialisation in that space, which is around activation of getting potentially either university or private, not only providers, but other businesses into that space to really leverage off the economic benefit of some of those livable health communities across New South Wales. We have a number of major spaces in that around not only our metropolitan, but also our more major regional hospitals. We are looking at things like Medi hotels around our Newcastle John Hunter Hospital. We're looking at how we have, innovation health hubs to be incubators for innovation and researchers where they might be directly aligned to adjacent university facilities and to our adult and children acute care facilities in some of those precincts. You can go to the next slide, thanks. Spoken a little bit about innovation and commercialisation, but we do have now an industry prospectus where each of our local health district partners and ourselves have put together system-wide opportunities that really support investment attraction. We are often purchasers of innovation from other countries, and what we're trying to do is to shift that dynamic and really be selling something to the rest of the world, and we do have some good examples of that. And we need to set up within our own government processes, not just within health, efficient systematic decision-making and how we triage some of those opportunities which are available. And we certainly have a much broader role in that now than we used to have at Health Infrastructure. We are more now than just being the builder of some of these facilities, and it's really how we leverage some of those economic outcomes. I just talk a bit more around some of our precinct context, and our viral vector manufacturing facility is one which we're putting into the Westmead precinct, which I'll come to in the next slide shortly. But we have an innovation ecosystem fund now at Westmead, and there are a lot of opportunities and some additional precinct spaces in what we call the Health Enterprise Zone, where we are just about to launch, getting other partners in that space. We are looking at key worker accommodation, which is a significant issue for us here, and also about family accommodation. And in that space, we're looking at where we may be able to have collaboration with our education partners to have schools, whether they be childcare for workers, state schools or university schools in some of our precincts. I'm not sure if, Catherine, you've got anything you'd like to add in this space, but one of the two key projects which we're working on with Catherine and her team is the stage 2 development of the Westmead precinct. And if we just flick to the next slide, thank you. It's a significant expansion of the paediatric services in Western Sydney, which is one of the fastest growing areas in Australia. And this image shows just a snapshot of the health projects which are being delivered concurrently in that space. We actually finished the new Westmead acute services hospital during COVID. We accelerated that in case it was required for a COVID hospital, which it wasn't. But we finished that early. We're now doing some refurbishment works in the older hospital. We are relocating the Cumberland mental health relocation, which was going to be one of the state's largest mental health acute facilities in that space. We'll have the viral vector manufacturing facility, which I just mentioned, and the paediatric services building. Precinct planning is really based on place-based planning, enhancing and strengthening the communities, which is bringing more value to our communities. Catherine, I want to just chat for a moment about some of that collaboration and the work that we're doing there about hopefully us not just providing infrastructure, but how we work together and collaborate in that space.
Thanks, Rebecca. I'll be brief. I think what's important as not losing the sight that we are there to provide core health facilities, but this is a really important economic driver. Western Sydney is a poorer area of Sydney in lots of ways. It's very ethnically diverse. We found through COVID some very vulnerable communities. Largest Aboriginal population lives in Blacktown, which is nearby. And so this development isn't just about healthcare, it's absolutely about being an economic boost to the region, providing jobs, diversity of employment, white collar employment. The other bit you'll see though as a precinct is also making it fit for place. So this really needs to be culturally welcoming to our Aboriginal families and children. It's got to be welcoming to babies and their parents through to adolescents with eating disorders. So it's absolutely critical that there's a really holistic approach to this whole idea of precinct and having the community feel welcome and able to come and receive care here. And so there's lots of green space, there's lots of play areas. I think what's really been delightful for me after many years of being in health services is engaging with children and young people and having them tell you what their expectations of healthcare are, and they certainly don't hold back, and it's the most delightful engagement that you can have from those consumers.
Thanks, Catherine. One of the other things that we're working on with Catherine and her team, and in fact across many of our projects, is an Arts in Health program, which is not just about hanging art on walls, but it's about engagement with different communities, to have artists create large-scale art, but also other programs, which could be to do with aged care programs, mental health programs around getting different arts into our hospitals just to make them better spaces to be in and for people to be more engaged, which the research is now showing absolutely assists people in getting better faster. And apart from that, in New South Wales, particularly in some of our remote and regional areas, the local health precinct, the local hospital is the biggest employer in town. And for it to be a better place for worker wellbeing as well as for patient and carer wellbeing, we're finding is increasingly important, and much better around workplace safety as well. I think that's the end of my slide pack. Just as a bit of an introduction of who we are and how we're important in the whole of the health ecosystem around providing infrastructure for better wellbeing. And happy to take questions or move into the panel now.
That's great. Thank you. Thank you, Rebecca. If we could just start actually, because we have a question directly for Catherine. If you can see that in the Q&A tool, Catherine, if you'd be happy to answer that.
Yes, I do think there's actually differences in new children's hospitals because we're really unique. We've got 1.3 billion and we've got 2 major hospital redevelopments. So I was interested in some of the standardisation approach, which Rebecca's been following as well here, because we describe our 2 facilities as siblings, not twins. So we try to have areas like the intensive cares the same and the same pendants, because we have staff obviously going between the 2, but we absolutely want them to be appropriate to place and part of their precincts and their community. I've got one on the eastern suburbs near the beach, and we've got another one in Western Sydney near the river, and HI have done an amazing job of making them for place. The other thing about new children's hospitals though is, said, I think you've got a baby's requirement. So a 1-day-old having complex cardiac surgery versus a 16-year-old with a really complex eating disorder, to actually provide a physical environment that is safe, welcoming, appropriate to age is a real challenge, which HI have partnered with us really, really well on. And I said, and that's where that different level of engagement with children and young people into their expectations, our colour schemes, our play areas, what's safe, line of sight, having parents room in. We've got all the ability of parents to sleep next to their child in the intensive care. Really different ways that staff have to think about models of care. parents have told us, stop making us coordinate the care, centre the care around us. You're actually here to provide care for us. So that's really made us think very, very hard about our models of care. So they're complex builds anyway, hospitals, as we all know. But I do think there's that layer of complexity with children and young people and their parents and carers.
Yeah, thank you, Catherine. I can also see that there's a question there from Mel, which I think there's a dual aspect to this question, actually, because I think our panel can answer in terms of their approaches with partnering and what works well, because obviously on any new health estates requirements, there are huge amounts of different parties, national, regional and local, involved to make that happen in different stakeholder groups. I'm happy post this session to talk about the complexities of stakeholder engagement around that. And I think there are two aspects. One is the actual care model, and then there are actual stakeholder engagement requirements around planning and construction as well. And there are different approaches involved in that. But if I can throw it out to the panel, first of all, just quickly, as we have a few minutes before we end, for anybody that would like to answer in terms of some of the key issues to be addressed when partnering with lots of different bodies and groups of people.
So I start off with that, Louise. So Nicola Theron. So one of the so collaboration is clearly is the golden theme around all that we're doing, but we have to build into that clear accountability around responsibility and particularly risk. And I would say that some of the collaborative programs I talked about, the Community Diagnostic Centre, has been a really important way of managing, of teasing out what those risks are for both the development and for an operational project, being clear who has responsibility, who is mitigating, how that mitigation takes place, how we operationalise it as far as possible. So it brings many of these issues to the surface. In some ways quite challenging conversations need to be had, but then captured within a document that reflects back on that sort of what's been quite a complicated journey of a discussion, but to get a conclusion that's got particularly finance director sign off, chief exec where required. But that management of risk is fundamental in order to make collaboration work, I would suggest. Hope that's useful. Thanks.
Great, thank you. And there's another question around how do you future-proof planning of hospitals when there's significant changes in MOC?
I'm happy to answer that, or at least try.
Yeah.
Well, we learned a huge amount through the pandemic around the need for hospital facilities to be genuinely flexible in their ability to provide the type of care that's needed at a point in time. So I think we learned an awful lot about the need for flexible space. And when I say flexible space, I just mean that we've actually thought through multiple ways in which we might use a department or a particular room. So in the NHS, for example, we would often not put in medical gases into a clinical room if we thought it might not be needed for the service that was going to be using it right then and there. But of course, then later on have found that that was really short-sighted. And so from the new hospital programme perspective, flexible space and flexible use of departments is something that we have thought about an awful lot. And not just really in order to think about the ability to respond to pandemics, but the ability to respond to any changes in healthcare requirements. So, I mean, that's a very sort of high level response, but for now, that's definitely what we're looking to do.
That's great, Natalie, thank you. I'm conscious of time. There is only 1 minute until we draw to a close. So I want to take the opportunity to thank our panel and thank everybody who's attended. If we've not been able to answer your question live now or a typed answer, then we will follow up with the answered questions as part of the summary document that will be sent out, along with the master presentation and the link to Nicola's video. Thank you all. I think you can all agree it's been an amazing session to share learning across the UK and Australia. And thanks for joining.
Thanks very much, everyone.
Thank you.
Thank
Thank
you.
you.
Bye.